So you are live now.
अच्छा, ठीक. आप introduction दें? You will introduce me?
No, sir, you can directly start.
Okay. Good evening, friends. I'm Dr. Pratik Tripathi. I'm Director of Nephrology and Kidney Transplant at NIMS, Jaipur. Today, I shall be discussing about particularly common kidney disease, genetic kidney disease, which is also which goes by the name of autosomal dominant polycystic kidney disease. Slides, please. Yes. So I shall be talking about autosomal dominant polycystic kidney disease. Next slide. It would be discussed under various headings that includes epidemiology and how to go about the differential diagnosis, because there are certain other entities, other diseases which also present with cyst formation, multiple cysts in the kidney. We'll also discuss about how this disease moves on, progresses, and then we would try to, I'll tell you something about how to figure out how bad things are so that you can take immediate steps. And then these things that one can do, the interventions to retard or reduce the rate of progression. So it will be, the topic will be discussed under these headings. Next slide, please. Next slide. So epidemiology, as per epidemiology, ADPKD is fairly common, 1 out of 1,000. And in fact, it is the most common inherited cause of CKD. If you go to a dialysis center, you will find approximately 10% of people on dialysis have this disease known as autosomal dominant polycystic kidney disease. Since I'm addressing doctors, you may have come across this disease very commonly, maybe even during your MBBS as well. As far as the sex ratio goes, it is more or less equal between male and female. As far as the etiology goes, it is autosomal dominant inheritance, as the name suggests. And the two most common types, that is type 1 and type 2, are due to mutations in the there is one in chromosome 16 in the gene PKD1. That is almost 80% of cases. And then there is something known as another protein known as PKD2. Its gene is located on chromosome 4. And this is the cause mutation in this particular gene occurs in 15% cases. And as for, there are different types of mutations and mosaicisms that can occur. And approximately 10% of these patients, in fact, will not have a family history. So that would be a so-called de novo mutation occurring in that particular person. Over a period of time, after genetic, with the developments in genetics, in genetic medicine, we have come to realize that there are multiple other mutations which can present in the same way as autosomal dominant polycystic kidney disease. In fact, it has been found that approximately 10% of these patients do not have a mutation in PKD1 or PKD2, and they have mutations elsewhere, somewhere known as DNA JB11. And also there is a relationship between the mutations which cause a disease known as autosomal dominant polycystic liver disease. So there are 6 mutations which cause it. Sometimes they tend to cause some renal disease as well. Next slide, please. Symptoms generally, the patients generally tend to present in their adulthood. Once they have crossed their teens, they're into their 20s or maybe early 30s. But certain mutations can be so deleterious that the disease can be very florid, and they can present even during childhood. And it has been seen that there is a difference between the presentations in PKD1 and PKD2. The PKD2 patients tend to present rather late, much later than PKD1 patients, and their disease tends to be less progressive than PKD1 patients. In fact, most PKD1 patients tend to have develop renal failure during their lifetime. Next slide, please. Now I'll talk about the various manifestations of this disease. As far as the renal complications go, one of the most initial present manifestation is dysfunction defects with urinary concentration. So this, in fact, presents during childhood, and they tend to have mild polyuria. Sometimes they can have nocturia and can cause bedwetting as well. Ultimately, hypertension also tends to develop, and this generally occurs once the GFR, in most patients, in fact 50% of these patients, it occurs much before the creatinine starts going up. So it's an early thing. In fact, some children may have hypertension as well. Some of these patients would have hypertension during their childhood. So if a child presents with hypertension, one should keep this in mind, and obviously the kidney should be screened. It is well-known cause of end-stage renal disease. As I said, 10% of patients on dialysis have this problem. And in PKD1, around almost every patient is on dialysis by 60 to 70 years of age. In fact, in the Indian context, I have been seeing these patients going on dialysis even in their early 40s. In PKD2, things may be different, and some of them may never go on dialysis. They may have proteinuria as well. Generally, initially, the proteinuria is not that significant, but afterwards, as the GFR starts declining, the proteinuria can increase, but it will never reach the level of so-called glomerular proteinuria, that is above 1 gram in 24 hours. If that is happening, then the possibility is that some other disease has superimposed on this particular disease. The kidneys become so enlarged that you can actually if you put your hand on their abdomen, you may even feel those kidneys, and you can feel the bosselated surface of the kidney. And they are carrying such massive, large kidneys, they tend to have a lot of flank pain. They would be complaining of flank pain, abdominal pain, and this would be a complaint which would be there from a very early stage. They can have stones as well, especially uric acid stones. Some can have even calcium oxalate stones, which can be very painful. Cyst hemorrhage tends to occur a lot, and some of these patients would present with gross hematuria. Urinary tract infection is a particularly dreaded problem in ADPKD, because the risk remains that if the organism ascends up into the kidneys, it can actually cause cyst infection and followed by septicemia. So that should always be kept in mind. And it is more common in women, because we know women tend to have more urinary tract infections. Some of these patients can have renal cell carcinoma as well. So a high index of suspicion is required for someone who presents with gross hematuria. Next slide, please. The extrarenal complications are there as well. It's a systemic disease. It's just not only confined to the kidneys. A lot of other organs get involved. It's been seen that the liver is the next organ which is most involved. And many of them tend to have a lot of cysts. And as the disease progresses, the number of cysts in the liver also increase, and the liver also becomes enlarged. It has been noticed that there is a dependence on estrogen in these patients. So postmenopausal women, they are somewhat protected from enlargement of the liver. But so especially in postmenopausal women, if you want to prevent UTI, you should not be using estrogen ointment, vaginal ointment in these patients. Cysts may occur elsewhere as well, like in pancreas, spleen, ovary, testicles, even the thyroid. And sometimes the pancreatic cysts can cause a lot of problems by obstructing the pancreatic duct, and it can cause acute or chronic pancreatitis. Uh, Cerebral aneurysms are common as well, and uh, approximately 10% of these patients. So 1 out of 10 ADPKD patient would be at risk. This is actually much more common. This is almost 5 times more common than in the normal population. And it has been seen that if there is a family history of someone having died of cerebral aneurysm rupture, then the chances increase. So I'll tell you about the situations where you have to actually go screen these patients for the aneurysm and intervene if it is present. Next slide, please. So, as I said, other extrarenal complications include liver cysts and diverticular, colonic diverticula. It is very common. Almost 80% of these patients, especially in advanced disease, would have it. Hernias are common as well, abdominal hernias. As I have already mentioned, pancreatic cysts, choledochal cysts, common bile duct dilatation, splenic cysts, these are all common. Arachnoid cysts can also occur. Sometimes spinal meningeal cysts can occur as well. Some may have bronchiectasis as well. Uh, Cardiovascular involvement is very interesting. Hypertension, as I said, is pretty common almost universal in these patients. They can have cardiac complications as well, like left ventricular hypertrophy, valvular complications, atrial myxomas, pericardial effusions, and coronary artery disease because of atherosclerosis. Sometimes coronary artery aneurysm or dissection as well. There can be dissection, aneurysm of other arteries like the popliteal and the splenic artery or the intracranial arteries. There can be dissection of the aorta. The aortic aneurysm can also form in these patients. And these aneurysms can dissect in other arteries like the internal carotid, the vertebral arteries, the iliac arteries. Next slide, please. See, these are the valvular defects. The mitral valve prolapse and mitral regurgitation are particularly common, almost 1/4 of these patients. Other regurgitations are also there, like aortic, tricuspid. Next slide, please. Let's talk a bit about the genetics in PKD. Next slide. PKD1, as I said, means bad prognosis. However, there can be various variations, and it's not necessary that someone who has PKD1 does badly all the time. PKD2 means that generally things are not that bad, but that it's not the rule. It's not the rule. So family history will actually tell you what is going to happen to the patient. If someone has got it from his father or mother, if the mother was on dialysis at 40 years, one would expect that particular patient would also possibly be on dialysis at that age. So there is a lot of overlap, however, and it's not always the rule. Next slide, please. As there can be so many types of mutations. In fact, at Mayo, they have tried to figure out the types of mutations, and they have done a lot of research. And PKD1, they have noted 2,300, more than 2,300 mutations. And in PKD2, they have noted almost 300 mutations. So, however, genetics, there are certain mutations which portend a bad prognosis, but it's not always true that genetics will explain everything. Next slide, please. Genetics generally should be done if, for example, you have an ADPKD patient and you have a family member who wants to donate, and you are not sure whether that person has the disease or not. You do a CT scan or an MRI, you find a few cysts, Those cysts may happen. They may be simple cysts. You don't know. They do not so-called fulfill the criteria of ADPKD. So you have to do genetic studies that these might be so-called mutations which are not really penetrated so well, or those they are not so significant mutations, but they are definitely causing disease. If, as I said, if the ultrasound or the CT or the MRI is not clearly telling us whether the person has ADPKD or not, you have to do genetic studies. Sometimes these patients, they have, cysts in the kidney, and then they would have other presentations, involvement of other organs like the brain or other places, and you wonder what is going on, and you do a genetic study. And of course, family planning. If a person has this particular disease, the child getting the disease from the mother, from the in that family is 50-50, if only one parent is having the disease. So one can plan, do genetic studies, and in antenatal genetic studies, and maybe plan the pregnancy accordingly. Next slide, please. Sometimes these patients can present with cyst hemorrhage. So I'll tell you why it happens. We'll discuss it later. Next slide, please. Now, ADPKD pathogenesis. Well, there is a talk about the 3-hit model. In fact, it was noticed by microdissection that only about 5% of the nephrons actually develop the cysts. The rest, 95% of the nephrons, which were absolutely normal, get destroyed because these cysts become enlarged and they compress the other nephrons and destroy their blood supply and cause fibrosis and inflammation. So the 3-hit theory says that the cells become cystogenic only after first hit, that is germline mutation, plus a second hit where there is a somatic inactivation of the normal LLA, and then that is followed by a third hit in the form of nephrotoxic injury or ischemia, which leads to cell proliferation and cyst growth. So in fact, those people who have the disease, the cysts are already present. They are microcysts. You cannot see them in the ultrasound. Even when the person is in utero, is still developing in utero. It's only later on with time, these cysts enlarge, and then you are able to see them on ultrasound and on CT and on MRI. And these cysts can actually arise from all segments of the nephron. They can even arise from the glomerulus. However, most of the time, they tend to arise from the collecting ducts. And those from the collecting ducts are always larger and they cause the maximum damage. Next slide, please. These are the functions of the PKD1 and PKD2. The polycystin 1 and 2. These are the proteins where the mutations are taking place. These are located in the cilia and other places in the cell, in the epithelial cells. And in fact, epithelial cells occur throughout the body. So this problem also can occur throughout the body. However, the kidneys are most commonly involved. And the function of the polycystins is it's involved in so many things like cell growth, cell differentiation, cell proliferation, cell addition, apoptosis, even cellular metabolisms, and the polarity. It also involved in fluid secretions. Even the mitochondrial dynamics is affected by these proteins, and cell-to-cell interactions and their extracellular matrix formation. So all of these things get affected and you have the disease. Next slide, please. So when these mutations occur, either in PC1, polycystin 1 or polycystin 2, there would be a disruption of various pathways. These pathways include the polycystin signaling pathway, the cyclic AMP pathway, the mTOR pathway, the JAK-STAT pathway, the ID-ID pathway, and the WNT signaling pathways, the G protein signaling. These are all things which are happening inside the cell. And all of them are getting affected, which is causing the cell to misbehave, behave a bit like a tumor, as a matter of fact. We'll see that. Next slide, please. This is how metabolic reprogramming is taking place. The affected cells do not function normally. They are producing more lactate, which is known as the Warburg effect, and uh, there is reduced fatty acid oxidation, and there is more biosynthesis of fatty acids, and mitochondrial functions are also getting affected. Next slide, please. So how do you make a diagnosis? Next slide. Well, diagnosis generally just involves imaging, which can be ultrasound, MRI, or CT scan. Ultrasound is most commonly available, and the cyst size generally has to be larger than 1 centimeter. With MRI, which is the most sensitive, the cyst size just about 2 millimeters, it can be detected, and even with CT scan, up to 2 millimeters can be detected. Next slide, please. So there would be a number of patients who would actually be requiring screening. Who are these patients? Those who have family history. For example, a patient comes to you with ADPKD. Now, you would wonder whether his children also have the problem. So you can screen them, and generally it is advised that since this disease is actually unpreventable, if it is there, there's nothing you can do about it. So you can generally delay the diagnosis, making the diagnosis till about 18 years of age. And once it is detected, then the patient should be told that he should inform his first degree relatives so that they also can get screened and get treatment. Next slide, please. So what kind of cysts are we talking about? What do we actually see? What we are looking at is diffuse. It is not only in the cortex or in the medulla, it is diffuse throughout. Diffuse bilateral cystic involvement of both kidneys, more or less symmetrically. It's more or less equally on both sides. Next slide. And the kidneys become enlarged. In most cases, the two things that you are looking at is multiple cysts throughout the kidney and the kidney becoming enlarged. Next slide, please. You have various radiographic criteria as well. Basically the clinical situation that we deal with are two. One is a person comes to you with multiple cysts and you are wondering whether he has ADPKD or not. Number two, a person has a family history of ADPKD and he comes to you and you want to see whether he has ADPKD or not. It is very easy for us to see the cysts. As I said, even 2 cysts can be detected. So it is very easy to confirm the diagnosis, but it may be sometimes be difficult to rule it out because the cyst may not have developed at that time, or cysts may be atypical because of various different types of combinations and permutations as far as mutations are concerned. When you find you are doing an ultrasound and you find multiple cysts, then you have to think about other entities which can produce this kind of picture. Next slide, please. This is the various criteria that we have to make the diagnosis. Next slide, please. Yeah, same thing that I just discussed. Next slide. Next slide. So these are the other entities which can also produce cysts, renal cysts, and they can be genetic or non-genetic as well. So genetic, you have ADPKD, tuberous sclerosis, von Hippel-Lindau disease, even medullary cystic disease, and autosomal recessive like ARPKD, juvenile nephronophthiasis, and other rare malformations. Then you have the X-linked disease like the orofacial digital syndrome, and then the chromosomal disorders like trisomy 21, 13, 18, or C. And then you have acquired cysts. They are pretty common as well. Simple cysts are very common. In fact, 50% of those aged more than 50 years of age may have a simple cyst. That is a thin-walled cyst with nothing inside. And there's something known as acquired renal cystic disease, where you have multiple cysts in a diseased kidney because of chronic kidney disease. And sometimes a prolonged hypokalemia, chronic hypokalemia, can also cause cystic dilatation of the tubules. Developmental diseases like medullary sponge kidney, how they develop, why they develop. Medullary dysplastic kidneys, little is known as to why they develop. Next slide, please. So this is how you go about the differential diagnosis. Next slide, please. Well, as I said, these patients can present with hematuria. So hematuria can be because of hemorrhage within the cyst. It can be because of trauma. It can be because of infection, carcinoma. And you have to think about unrelated things like bladder CA as well. Next slide, please. Now, once you have made a diagnosis of ADPKD, the next step should be to find out how this person is going to behave, how the disease will behave in this person. So how do you go about it? Next slide. It has been seen that by the time the creatinine actually starts going up, the things are actually very advanced, because initially there is a so-called normal phase where their cysts are not that much. And then you have a phase where the cysts are more, but there is hyperfiltration. So the creatinine stays normal. And the moment you have impairment, that means even the so-called hyperfiltration phase has gone past, and the number of nephrons the attrition of nephrons have exceeded more than 50%, and things are pretty advanced now. And from then onwards, the descent into requiring dialysis can be quite rapid in these patients. So one should try to intervene even before the creatinine has gone up or become abnormal. Next slide, please. The various factors which affect the prognosis include the genetics, that is the type of mutation, the other things like epigenetics also. These are things that we are learning about now, how the DNA methylation or histone modification is taking place. There are so many environmental factors involved here as well, like fluid intake, salt intake, calorie intake, protein intake, and the BMI of that person. There are certain things that we utilize to find out how things are, to prognosticate, and these are clinical things. Like if someone develops hypertension quite early, that means things are going to go wrong with that person. If someone has multiple times gross hematuria, that means the person is going to have a bad time. If the person has recurrent infection of the cyst, that person is going to have a bad time. And imaging also, we find out the total kidney volume, and the other things like the length of the kidney. And then there are other biochemical things that we are looking at, like the serum creatinine to find out the GFR, and the urine protein. If someone is having significant proteinuria, things are going to be bad with that person. Next slide, please. Yeah, so this is exactly what I was talking about. And of course, environmental factor, other things like smoking. If the person has been smokes a lot, drinks a lot of tea, he's going to have a bad time. Next slide. So various methods of prognostication are there. One is genotyping. The other is CRISP2 and CRISP3. Other is something known as the Pro-PKD score. I'll talk about it. And then you have the Mayo-imaging classification, and then you have the image texture analysis. These are all methods used to find out who is going to have a bad time, who is going to suffer, who is going to have a more rapid progression. The most commonly used are Pro-PKD and Mayo-imaging classification. Mayo-imaging is much easier because you don't have to do a genotyping or anything of that sort. You just have to do the imaging. Next slide, please. Next slide, please. So this is pro-PKD. Pro-PKD is a mix of clinical and genetic factors. So you look at the mutation type, and you also look at the other things like when was hypertension present, what is the sex of the patient, and when did that person have a urological event like hematuria. And based on that, you can predict what is going to happen. So uh, uh, people who have early hematuria or early hypertension, or who have mutations, non-truncating PKD1 mutations, they tend to have a bad time. Truncating mutations, they tend to have a bad time. Next slide, please. Now, kidney volume, it has been noticed. I mean, logic also tells you that the larger the cysts, as I said, only 5% of the nephrons are getting involved by cyst formation. So the rest of the nephrons get destroyed by these cystic nephrons. And these cysts, the larger they are, the more damage they will cause. And the larger they are, the larger the kidney will be. So you just have to measure the volume of the kidney, and the larger a person's kidney, the faster that person's disease will progress. Next slide. In fact, people have seen that uh, you know the larger kidneys, you could actually see the difference between those people who are going to have a bad time and those people who are not going to have a bad time. Almost 6 years before their creatinine started going up. So those whose kidneys were larger, you could predict almost 5 to 6 years before they started having a bad time. So this is how this came about, and now this is something that is done regularly. Next slide, please. Next slide. Yeah. So how do you actually measure the volume? You can use the MRI, you can use the CT scan, and there are various software programs which tell you what is the volume of the kidney. So you have a list here: live wire tools, stereology, mid-slice method, ellipsoid method, etc., etc. It's the ellipsoid method which is used most commonly because it is very quick. It gives you a rough volume of the kidney in a very short time, maybe within 10 minutes. Next slide. These are the classifications of the disease. So average change, if the change is great, you do it serially. You do the volume estimation serially, and those whose kidneys are growing faster, they will also be losing their kidney function faster. Next slide. Next slide. This graph shows exactly that. The larger the kidney, the faster the progression of the disease. Next slide. This is the classification. So the class 1E, it has the most rapid progression, and class 1A has the least rapid progression. Next slide. Sometimes you have atypical, that is class 2 atypical. It can be situations, the cysts, unilateral, segmental, asymmetric, lopsided. So you have class A, class 2A and class 2B. So class 2B tend to have a worse time. Next slide. You can also simply measure the length of the kidney. If it is more than 16.5 centimeters in a patient who is less than 45 years of age, you can be sure that person is going to be on dialysis pretty soon. So the abnormalities in creatinine are late findings, and we can always predict who is going to have a bad time by simply serially measuring the size of the protein, the size of the kidney, by looking at the volume or the length of the kidney. Next slide. Uh, uh, this just emphasizes the points which I've been saying about the natural history of the kidney. of this disease. The larger the kidney, the faster the progression. Next slide. Now the treatment, see, the treatment is, we know that we cannot cure this disease, but we also know that we can try to slow down its progression. And how do we slow down the progression? By slowing down the size of cyst enlargement. So if we slow down the size, the speed at which the speed at which the cysts are enlarging, we can protect, maybe give that person a more time, protect him from coming on dialysis earlier. Next slide. So we apply every patient who comes to you. The same rule number one is applicable to everyone. And what is that? Rule number one, most important rule, is blood pressure control. It has been seen that you have to have a very strict BP control, less than equal to 110/70 in these patients, to slow down the progression. And we prefer ACE inhibitors and angiotensin receptor blockers in these patients. I'll tell you why. Of course, salt restriction is across the board. Caffeine restriction is across the board, because taking caffeine will increase cyclic AMP within the cysts and will cause cyst enlargement. It has been shown very clearly that if you restrict the calorie intake and avoid obesity, you will protect the kidneys. So obese people would have will put additional stress on the kidneys. Smokers will produce more stress on the kidneys, so no smoking. You can give statins as well, like atorvastatin, which has pleiotropic effects and tends to have antifibrotic effects as well. You have to give vitamin D, like cholecalciferol, which also protects the podocytes and has pleiotropic effects. You generally try to avoid diuretics in these patients, because the more salt passes into the tubules, the greater the cysts are going to enlarge. So you may use diuretics very sparingly in these patients. And they have to have a high fluid intake, because it has been seen there is a direct connect with vasopressin. So if more vasopressin is produced, or concentrated urine is produced, the cyst enlarges more. So vasopressin, you have to suppress the vasopressin production, and that you can do very cheaply by drinking a lot of water. Your patient can do very cheaply by drinking a lot of water. And of course, you can always use the vasopressin antagonist, which is tolvaptan, which is somewhat expensive, and which should only be used in a subset of patients. We'll find out who are those patients. Next slide, please. These are the various reasons why these people have hypertension, because of cyst compressing the renal vasculature, causing renin, which is increasing the angiotensin, which is also increasing aldosterone. And then there is a lot of other things happening, like sympathetic activity and TGF beta activity, causing fibrosis and salt retention. So that's why ACE inhibitors are preferred here. Next slide, please. In fact, it has been seen that calcium channel blockers may have detrimental effects, especially in animal models. Though in humans, it's not very clear whether that is the case, because we tend to use a lot of calcium channel blockers even in these patients, because some of them can have really uncontrolled hypertension, and then you have to use calcium channel blockers. Next slide. So this is how you go about it. First, you confirm the diagnosis of ADPKD, and then if it is typical ADPKD, you take the usual, you prognosticate that person, you find out the total volume, and then according to the class, you take effect. You take some steps. If that person falls in the class which is going to progress rapidly, and the GFR is reasonably preserved, and the age is also not too much, then you can start tolvaptan in these patients. And where the class according to the Mayo classification, the class tells you that it's not going to progress very rapidly, then you can reassure and maybe withhold tolvaptan till a stage where it's really required. As I said, the general measures apply across the board, and they include good control of BP, sodium restriction, good hydration, body weight control, calorie restriction. Uh, some protein restriction is also required here. And if and when they develop acidosis, you have to take care of the acidosis by giving bicarb supplementation. And you take care of the dyslipidemia and by giving statins. And that's it. Next slide, please. So who are the people who are going to require tolvaptan? Tolvaptan is for people who are going to have a rapid progression and still have reasonable renal function. That is more than 25 ml per minute. And they are reasonably young. So you can give tolvaptan to these patients, and up to 90 milligrams of tolvaptan per day has been used in these patients. However, tolvaptan has a major problem. It can cause hepatotoxicity. Next slide. So this is here is a regime of how you give tolvaptan. You have to monitor the liver functions and titrate it slowly, escalate it to the maximum dose which you can give, and then of course you have to monitor the urine osmolality as well. You'd like to keep it low, below 280 milliosmoles per liter. This is how you go about it. Next slide. The benefit is that it has been definitely been shown to reduce the progression of the disease, but the harm is that it can cause polyuria and nocturia and thirst and fatigue, and uric acid can go up sometimes, and the liver dysfunction can occur. Sometimes people have died of fulminant hepatic failure, and it's expensive, and it has interactions as well, drug interactions. Next slide. So there are other symptoms which can occur in PKD. Next slide. Like pain, hematuria, stones, and these occur in almost 1/4 of these patients. They would have some pain or the other, and they would be having hematuria, and they may even have stones, and you have to do something about it. Next slide. Some of these people can really have a bad time. Now, the pain doesn't mean that only the cyst is enlarging and that's why there is pain. There can be so many reasons. If there is acute pain, you have to think of UTI or cyst infection or nephrolithiasis or hemorrhage within the cyst. And if there is chronic pain, it can be mechanical back pain because the kidneys become so enlarged that they produce stress on the lumbar vertebra. Next slide. Some people really have a bad time. You have to use non-steroid. You have to use paracetamol, tramadol. Sometimes they require opioids as well. Sometimes you have to go to the extent of denervation, renal denervation, celiac block, things like that. Next slide. A class of patients would be susceptible to having aneurysmal bleed. So who are these patients? If there is a family history, and prior to a major surgery, because for example, transplant, if somebody who has ADPKD is going for transplant, you have to find out whether that person has this problem or not, regardless of family history or not. If a person has ADPKD and plans to become a pilot, then obviously he has to be evaluated for this particular entity. If there is acute onset of headache, then it should also be looked for. And if the patient says that, yes, please screen me, I'm worried I might have this problem, you have to screen it. Next slide. There are other treatments which are being tried because, as I said, the treatments are just about one treatment is available at the moment, so-called treatment. But people are trying other things as well because they know now in some detail as to how the cysts are forming. So they are trying different drugs, refashioning different drugs. So next slide. So these are the various places where the intervention can be done. For example, the mTOR inhibition. Once upon a time, sirolimus was also tried for this, though it did not become popular because it tends to cause a lot of problems. Other than the benefits, the risks were apparently more. Metformin has been used. Curcumin, that is haldi, has been used as well, and there are studies going on it. Something like somatostatin analogs are being used. Something like uh, even metformin, as I said, pyrimethamine is being also being used. So these are the various drugs which are being tried right now. Next slide. Next slide. These are the various drugs which are being tried. Niacinamide, that is, it's also been being tried. B1. Next slide, please. Pioglitazone and aldosterone antagonist like spironolactone is also being tried. Next slide. These are various reports of those in animals and non-animals. Next slide. So it's been seen that these people obviously die early if they do not get the full treatment. If they have, so these patients can die early, the PKD1 patients. And the major cause of death is, in fact, cardiovascular. Almost 50% of them are dying of cardiovascular disease. Approximately 15% are dying of infections. Some of them are dying of strokes. And then there would be some other causes as well. And particularly coronary artery disease is pretty common in these patients. So maybe it makes a lot of sense to screen for this entity before going for transplant. Next slide. This is what I've been telling you about taking care of blood pressure. I mean, first you make the diagnosis, then you prognosticate, then you decide whether you give tolvaptan or not. And of course, you treat them universally with the other drugs which are available. And then you can try the various experimental drugs provided you can. There are no contraindications like pioglitazone or metformin, etc., etc. Next slide. As I said, before even creatinine goes up, uh, intervention may be done because you can find out who is going to have rapid rise of creatinine. So it makes a lot of sense to refer a person who has ADPKD to a nephrologist at the earliest so that all these things can be done. Next slide. This is regarding transplant in these patients. This is a hardcore nephrology, so I would not discuss it. We'll discuss it later. So I think I've come to the end of my talk. I would love to have questions. Thank you.
Sir, I posted a question in private chat. There are two questions from the audience.
Yes.
So there are two questions from the audience I posted in the private chat.
Okay.
Yeah.
How do I see that? Where? Okay, you have sent something. Chat. Okay. Yeah. To what extent is the age of onset of high blood pressure and indication of prognosis and age and stage of the disease? I said, I mean, those people who have a rise in early rise in blood pressure, because as I said, it's part of the prognostication process. They are going to have more progression of disease, and in fact, as far as the treatment goes, even before tolvaptan became available, or even despite tolvaptan becoming available, we have noticed or we have seen that the blood pressure plays a especially big role in retarding the progression of disease. So control of blood pressure is very important here. And the targets are more strenuous than other places. So it's a blood pressure of less than or equal to 110/70 in these patients. The ultrasonic guide, this, could you show me my slides, please? Hello?
Yes, sir.
Please open the slides, please, again.
Yes, sir, just a minute. Sir, which slide do you want us to share?
Go on. Next. 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 Come to diagnosis. Yeah, next. 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 Yeah. So see, I mean, the criteria, as far as the criteria goes, the sonography goes, you are basically a person, whether he has a family history or not. So family history, if less than 30 years of age, if there are 2 or more cysts in one kidney or even both kidneys, between 30 and 59, if there are 2 or more cysts in each kidney, and over 60 years of age, if there are 4 or more cysts in each kidney. So this is the criteria for ADPKD type 1, where you have a family, the patient has a family history. Sometimes the person may be that, he's not sure about, or he or she is not sure about the family history, and however he or she has cysts. Then, from 15 to 39 years, it's 3 or more in one or both kidneys. Between 40 to 59, it's 2 in each kidney, 2 or more in each kidney. And more than 60 years, it is 4 or more in each kidney. These are ultrasonic criteria. They were first developed by Pai in Hong Kong. And so over time, they got somewhat more refined for various situations which can occur. Next slide. Next question. Any question?
No, sir, this was a question. Thank you so much.